Welcome to the Brilliant Fertility Podcast. I'm your host, Dr. Katie Rose, and this podcast exists to help illuminate the path ahead of you. With expert interviews, clinical pearls, and real client success stories, my intention is to bring you hope for what's possible on this journey and to give you tools and resources to navigate the ups and downs on the road before you. If you find this podcast helpful, don't forget to subscribe on your favorite listening platform. And I have a big request. If you have a minute, can you leave us a 5-star review? And let us know, what did you learn? What did you come away with? Did you leave with that spark of hope? This helps more people like you find the podcast. My mission is to support as many humans as possible on their path to become parent. And by you sharing and subscribing, you're part of that mission too. And I'm so grateful for you for being here. Welcome back to the Brilliant Fertility Podcast. It is September. In some areas of the world, you might be experiencing some fall weather. It's still hot as hell here, but September is also important because it is PCOS Awareness Month. And when it comes to infertility, PCOS is actually one of the top contributors to infertility. It is estimated that up to 80% of people with PCOS will struggle with fertility. So it's a really important condition to cover on this podcast. Heck, there are podcasts who are completely dedicated to PCOS. And it's estimated that this condition, polycystic ovarian syndrome, actually impacts 10% of people with ovaries. Guys, that's a huge number. And given the volume of people who have this diagnosis, it's also incredible in a negative sense how little research we have on it. It's growing, but we really need more dedicated research to this condition and how to treat it effectively. We do have some ways of treating PCOS that are very effective for some people. And so I will cover the generals of what to be looking for in a PCOS provider. But let's start by talking about the diagnosis of PCOS, because the diagnosis itself can be just filled with problems. And it can start at a very young age. So, when someone first gets their period, we're not necessarily given proper education on what to expect and what is considered a normal menstrual cycle. So what I see in my practice is a lot of women who started their periods were wildly irregular in adolescence. And before much investigation could be done, they were told, take birth control, it's going to regulate your cycles. And while birth control will provide someone with a regular bleed, it's not actually getting to the root of why is someone bleeding irregularly in the first place. So it's really helpful to have an accurate diagnosis. And it's gotten easier over the years to diagnose PCOS. They've changed the criteria for this. So with a good history and lab work, we can usually diagnose PCOS in a pretty straightforward way at this point. Let's talk about what that criteria looks like. Again, it has changed a little bit over the last few years. Number one, someone who has irregular cycles or anovulatory cycles. So this typically means that we see someone who has periods that are at least 35 days apart. So 35 days from the first day of one period to the first day of the next. Or irregular bleeding that would indicate they are not ovulating, or maybe they are just going months and months without a period. In the case of women who are bleeding frequently, this is really important to, of course, do a ultrasound, a pelvic ultrasound, where you can look at the lining of the uterus and ensure that there isn't anything else that might be going on there. I'm getting off on a tangent, but women with PCOS are also at increased risk of endometrial cancer. So as a side note, it's a good idea to have an ultrasound done for a couple of reasons. Back to our criteria. So we have that first one of irregular cycles or anovulatory cycles. The second criteria is having high androgens. So on your labs, this would be testosterone, free testosterone, DHT, androstenedione, DHEA. I'm going to get into in a second. It's not actually an ovarian hormone, so it's a gray area there. Or someone who has symptoms of high androgens. So this can mean cystic acne, hirsutism, which is hair growth where you don't want it. It's often on the chin, the chest, the belly, or thicker, darker hair on the arms and legs. The type of hair loss that includes the temples and the crown, often considered like an androgenic type of hair loss. And some people will exhibit weight gain and difficulty losing weight despite making lifestyle changes. The third criteria is that they either have the sign on ultrasound that indicates lots of immature follicles. So these are the cysts of PCOS. They're not true cysts. So if you've ever heard of someone having an ovarian cyst rupture, or if you've ever experienced that awful scenario, I've been there, it's rough. These little cysts are different. These are immature follicles. And these are important to identify because this is part of why women with PCOS or people with PCOS aren't ovulating. We have all of these immature follicles lined up, and the communication between the pituitary and the ovaries is thrown off by this hormonal environment that includes excess androgens and often the communication that's happening in the brain. So when we see this, what's called string of pearl signs on ultrasound, which is like when we have a certain number of these little immature follicles are lined up, they don't have anywhere to go, so they're not ovulating. Or if we don't have access to that ultrasound, but we have tested AMH on blood work and AMH is high, that is also now part of the diagnostic criteria for PCOS. And that does make our life a little bit easier because sometimes we don't always have access to be able to order all the things, or we're getting bits and pieces of records from places when someone's been told, you don't have PCOS. And it's like, oh gosh, you've got a lot of characteristics going on here. Let's get into the nitty gritty and see if all of these match up to meet this criteria. Even with those criteria, there's a lot of variation between what someone will experience with PCOS. And the big question for most of you here is, can I get pregnant with PCOS? And thankfully, this is one of the conditions that causes infertility that is highly treatable. Both with holistic methods and with Western medicine, we can usually get people with PCOS pregnant. So that is the reassuring bit, right? The frustrating part of PCOS is that it's a complex condition and it doesn't just impact the ovaries. There are some systemic involvements as well that we need to be aware of that can impact the health of pregnancy. So first and foremost, what I want to talk about with these factors is that the Western treatment doesn't address them. So if you've gone to an OBGYN, if you've gone to a reproductive endocrinologist, oftentimes the conversation is solely focused on how can we get you ovulating with XYZ medications, or eat less and exercise more, which like barf face emoji, all the things. I'm so frustrated with that advice because it's not based in good quality research. It is purely based on looking at the size of someone, looking at their BMI, and we know that those are not good indicators of someone's overall health and fertility. So when we are relating what are the differences between how a naturopathic doctor, a holistic, PCOS trained dietitian, an acupuncturist might approach someone with PCOS, like we're looking at the whole picture, we're looking at the whole person. And on the Western front, they're often just looking at how can I make this person ovulate? So the drugs that are used in Western medicine to enhance or induce ovulation are typically Clomid and Letrozole. Now, I don't have any beef with these drugs. Like, these can be really amazing tools when they're used properly and they don't get to the root causes. So let's talk about root causes of PCOS. In part, there is a genetic contribution. So this is challenging because we can't just cure PCOS that we're aware of at this point. With the specific gene involvements, there's always going to be this predisposition towards these symptoms. But there are also factors that can exacerbate PCOS. It can make the symptoms worse. And given the biggest factor that affects fertility with people with PCOS is infrequent ovulation or just not ovulating at all, anything that we can be doing to support someone ovulating more often will increase their chances of getting pregnant. And so when we look at these factors that are influencing how someone does or doesn't ovulate, I'm looking at inflammation, I'm looking at nutrient deficiencies, insulin resistance, and stress resilience. So if we have a situation where someone is highly inflamed, they're deficient in a lot of the nutrients that are necessary for everything from ovulation to fertilization to implantation. If they have high average blood sugar that's creating oxidative stress, and if they have a lot of emotional stress, this is all going to be contributing to an environment where it makes it very difficult for one of those follicles to finally reach the point of maturation and ovulate. When we look at the hormonal environment, something that's really important to know for people with PCOS is that for a lot of them, LH, luteinizing hormone, the hormone that you may be familiar with that is tested by ovulation prediction kits, this can be high all cycle long with some people with PCOS. And it's in part related to how the brain, how the hypothalamus is communicating with the pituitary. So the hypothalamus is producing this hormone called gonadotropin releasing hormone. And in people without PCOS, this has a very rhythmical pulse rate. So it will be pulsing slower throughout most of the cycle. And then as it's getting feedback that, okay, this follicle is almost ready to go, it will start pulsing faster. And as it pulses faster, that will tell the pituitary gland to make more LH. And that LH will surge. And about 24 to 36 hours later, the egg is released. And that LH is like the trigger hormone to just make it just pop right out of there. I have that horrible image of the Kool-Aid man busting through a wall at ovulation. Someone posted a meme probably 8 years ago about that. And every time I think about ovulation, that pops into my brain. I'm sorry / you're welcome if that now is in your brain too. But that's part of the hormonal environment with PCOS. And with that high LH all cycle long due to a chronically fast pulsing GnRH, that LH is also signaling the ovary to produce more testosterone. We also have a picture where most people with PCOS will have some involvement of higher blood sugar, difficulty regulating blood sugar, insulin resistance. And what's very interesting and frustrating about PCOS is that with insulin resistance, the body itself, for the most part, all the cells in the body become resistant to that insulin. And so even though there's more and more being produced, we can't get sugar from the bloodstream inside the cell very effectively. But the ovaries still have some sensitivity to the insulin. So as the insulin is binding, it's actually telling the ovary to produce more testosterone. So we have these factors that can impact how testosterone is produced, and this can also impact how often or whether someone can ovulate. So if we have higher testosterone, if we have higher LH all cycle long, we're less likely to see ovulation happening on their own. So when we use medications like letrozole, which is now the favored medication to induce ovulation in PCOS, it doesn't have much of an impact on testosterone itself, but it does block the production of estrogen. And when we have a reduction in estrogen, the pituitary will produce more FSH. And then when the letrozole is withdrawn after a few days, that estrogen or the ovary is now stimulated by that FSH so that we're more likely to get follicles maturing. So my concern about solely relying on medications for ovulation induction without also addressing the root causes is that, yes, we may be, pushing that person's body towards ovulation, but they're still inflamed and they still may have other hormonal involvement or nutrient deficiencies or thyroid issues that could be impacting the quality of the egg, the ability to get pregnant, the ability to stay pregnant. So oftentimes what you'll see with someone who is going to a reproductive endocrinologist with PCOS is they'll advise, like, okay, maybe it's a good idea to lose a little bit of weight. They often don't give good guidelines on how to safely and healthfully lose weight. It's just based on some research that showed that even a small weight loss of 3 pounds could potentially make a much easier time to conception. But I've heard, everything ranging from you can't have any carbohydrates or even fruit whatsoever to just eat less and exercise more. And again, those aren't real research-based guidelines. What we want to see is this full-bodied treatment, right? I'm going to beat that dead horse until everyone walks away from this episode nodding their heads like, yes, okay, I need a full body approach to support my PCOS. So with an endocrinologist or reproductive endocrinologist, they'll usually do several medicated cycles with timed intercourse. So they'll use these medications to induce ovulation. Sometimes that includes letrozole and a trigger shot. And then they'll just time that with intercourse. If that doesn't work, they'll often progress to medicated cycles with IUI. So similar medication profiles, but then also using intrauterine insemination. If a few rounds of that didn't work, they're generally then moving into IVF. And again, IVF is a miraculous tool and it's not addressing the root causes. So let's go there with those root causes. What am I looking for in someone's picture, in their lab work, and how would I be approaching this in practice with my treatments? When I'm looking at the whole picture of PCOS, I really want to understand, is there one major factor that is driving their symptoms and their cyclical or lack thereof picture? So are they getting regular periods? Are they getting periods at all? Are they ovulating? How often are they ovulating? Is there any pattern that we can notice here? Do they have symptoms that tell us there might be a lot of inflammation? So this would include like the inflammatory cystic acne, brain fog, fatigue, headaches, muscle aches, joint pain, and it's like a deep fatigue. And if you've had it, you know exactly what I'm talking about. My experience with it is oh my gosh, it's just like you're just slogging your way through. Like you can push through it, but it feels like heavy. So that's one of the symptoms that I'm looking for related to inflammation. Insulin resistance type symptoms include weight gain, inability to lose weight despite eating less and exercising more. And I will tell you, I have had patients who come to me exercising 2 hours a day, eating 900 calories a day, and still unable to lose weight. And I just want to say, like, it is not your fault. It is a very frustrating component, and it is not your fault. So when we're looking at this insulin resistance, we've got often this picture of weight gain. Often there's more weight around the middle involved, sweet cravings, brain fog or bloating after eating. It's almost as if like the body just can't assimilate the carbohydrates effectively. And then we want to look at the factors of like stress and even just having PCOS is a stressful situation, being diagnosed with this, not knowing what's going on in your body. I can relate so much because when I came off of birth control after being on it for almost a decade and I didn't get a period, it was so confusing. Like no one had told me what to look out for. And being in the world of naturopathic medicine, like I really wanted a root cause answer. And my very Western OBGYN tested some hormones, said they're normal. And you guys, it was like 3 hormones that were tested and not any of the ones that can really give you much information about if someone has PCOS. So that's a story for a different episode if you go back to episode 2, I believe. But with some of these symptoms, we can get more narrowed down into what do we need to be testing and how do we need to be approaching this treatment. In general, there's some features of a protocol that everyone with PCOS would benefit from. So getting better quality sleep, avoiding endocrine disrupting or hormone disrupting toxins, learning how to regulate the nervous system, learning how to structure a meal that keeps blood sugar generally balanced for most people. These are things that all people with PCOS can benefit from. And there's some great resources that we have out there now that we didn't have 14 years ago when I was going through this journey of trying to figure out what the heck was going on in my body. I'll link some in the show notes. Shout out to one of my favorite resources, A Balanced Approach to PCOS is a book written by Melissa Groves, who is a dietitian who specializes in PCOS. And it is what it says. It just gives you a very balanced approach to meal planning and recipes that tell you how best to structure your meals so that you can keep your blood sugar balanced and you're getting enough fiber and antioxidants. All right, some other things that we have to keep an eye out for with PCOS. One is thyroid disease. So studies have shown that up to 27% of people with PCOS also have the presence of TPO antibodies, otherwise known as thyroid peroxidase antibodies. Now, these antibodies are also present in Hashimoto's. Hashimoto's is an autoimmune condition of the thyroid that often presents as hypothyroid. But what's interesting about Hashimoto's is it's ultimately a disease of the immune system. You know, the body is attacking itself for some reason. So there's a lot of inflammation involved, and stress can be one contributing factor. And so some of the symptoms of PCOS and Hashimoto's overlap each other. And oftentimes the patients that I see with PCOS have been written off as like, oh, well, that's just your PCOS, but no one's really looked in depth at their thyroid. And once we start treating their immune system and their thyroid properly, a lot of their PCOS symptoms start to improve as well. So with all of my PCOS patients, I run a complete thyroid panel that includes TSH, free and total T4 and T3, and the thyroid antibodies, thyroid peroxidase, and thyroglobulin antibodies. And this just gives me a much better idea of how these hormones are interacting with each other. Thyroid is something that is very involved in your metabolism. So when it comes to having issues with blood sugar regulation or insulin resistance, If someone also has low thyroid hormone, that is going to make those pieces of the picture much worse as well. Okay, and then nutrient deficiencies. Vitamin D is far and away the most common nutrient deficiency I see in my practice. It's a really common deficiency that we see in PCOS. And guys, it's so easy to test and treat for vitamin D deficiencies. I like to see a range, and this is, of course, in United States units. This is also educational purposes, right? So any changes that you want to make to your supplement protocol, please go talk to your doctor about. But I'm usually looking to get vitamin D levels between 50 and 70. Levels over 50 have shown to be protective and potentially preventive of miscarriage. So that's one reason for that. But vitamin D also has a lot of hormonal involvement. So when we have adequate vitamin D levels, we tend to see improvements in energy, in mood, in bone mineral density. Just, I think there's like 43 documented processes in the body that vitamin D is extremely helpful for. So this typically means people are taking higher than average doses that you would see in like a prenatal vitamin or a multivitamin. A lot of my clients are taking somewhere between 2,000 and 10,000 IU, just very tailored to what their lab work says. Another deficiency that I see quite commonly is iron. And this is especially true for the people with PCOS who are bleeding frequently, and they might be bleeding, for 20 days a month. And that chronic blood loss means that you're chronically losing iron. And if we're not replenishing that iron, that impacts egg quality, that impacts energy, it impacts our cells' ability to literally produce energy. Like we need that iron to carry oxygen where it needs to go in the body. So I'm very attentive to what labs we need to be addressing to investigate iron more deeply, because it goes beyond just looking at a CBC and saying, oh, your hemoglobin, hematocrit are okay, call it a day. It often takes like a much lower iron level to result in low levels of those factors. So I'm looking at ferritin, I'm looking at iron saturation and transferrin saturation and TIBC. And this gives me a much better understanding of how this person is utilizing iron and if they might need supplementation with it. So those are some major factors. These are some, tests that I might run. And in terms of what other supplements I might use, because I know it's such a common question of like, what supplement can I take for PCOS? Is myo-inositol really better than metformin? This very much comes down to the individual. So I can't give you a prescription in a podcast. I can tell you that we have some really promising studies on myo-inositol for helping to regulate blood sugar. I can tell you that berberine can outperform metformin for some people, although I'm very cautious about who I use berberine for, how long we're using it for, and it is not recommended to use it while you're trying to conceive, because there are compounds called alkaloids in berberines that are believed to be able to accumulate across the placenta in the baby's liver, and that could be dangerous. So I'm cautious with supplements. I use a very targeted approach. In general, myo-inositol is considered very safe. It's typically well tolerated, but we have to follow the lab work and what other things we're noticing in someone's picture too. So I don't want to demonize metformin. It's, an old drug. It's been around for a long time. It is generally considered safe, but it also comes with some pretty unpleasant side effects for some people. So if you find that metformin causes you to run to the bathroom frequently throughout the day, then it might not be our first choice. As best as I can, if it's compatible with someone's desired timeline for when they want to get pregnant, I do try to influence as much as we can with nutrition, exercise, and lifestyle. But I know that some of you in our Instagram question sticker had some questions about, is there a best diet? Is there a best way to exercise for PCOS? A lot of you who felt like you are doing everything and nothing is working. And where do you go from here? And while I don't know what everything means, I can appreciate that a lot of you have tried a lot out there to get improvements of your PCOS symptoms. But let's talk about diet and exercise. There is no one diet that is considered best for PCOS, although a high protein, high fiber, high antioxidant diet is where I see the best results in my practice. With a lot of other colleagues who I've worked with, who I trust with PCOS, and who've also seen good results in their patients and clients. That is what we're seeing as well. And some of the studies that we have on a high fiber diet have been very promising as well. So I don't tend to tell people to avoid entire food groups. Honestly, I was guilty of, 13 years ago, like, telling people gluten-free, dairy-free, sugar-free, alcohol-free, caffeine-free, like basically let's just cut out all the fun from your world. But the research actually doesn't show that that is necessary or helpful. The Mediterranean diet is probably the closest to that way of eating. And that basically includes a lot of produce. So unlimited vegetables, a little bit of fruit, beans, nuts, and seeds, whole grains, a little bit of dairy, meat and fish. And, those proteins, like a little bit of protein goes a long way. And I know when people think about, like, my advice is often to get about 30 grams of protein per meal. That can feel like a lot, but if you are eating meat, if you are eating fish, that's only about a palm-sized piece of animal protein. Totally separate conversation, of course, for people who are plant-based that we'll probably have to have a different episode all about. But that's where I emphasize the meal structure. And again, I would highly recommend Melissa Grove's book about that. When it comes to exercise, the guidelines for exercise with people who have PCOS who are trying to conceive are different than people who do not have PCOS. So women who have PCOS should be encouraged to engage in what's considered vigorous aerobic exercise and resistance training to optimize the chances of conception. When we say vigorous, this typically means like getting the heart rate up, about 70% of max heart rate, and aiming for 180 minutes a week. So about 30 minutes a day at least. And with resistance training, this can mean yoga, this can mean body weight, this can mean Pilates, this can mean lifting weights. I think what's most important if someone has not been exercising regularly is to start slow, start small, and stay consistent. It can take quite a long time to see physical results with exercise for people who have PCOS. Some of the studies have shown that it's actually taken about 50 training hours to achieve results, so months. But at that rate, when they've looked at these longer term studies with exercise and PCOS, that 50 training hours is associated with lowering AMH, which tells us, oh, we have less of those immature follicles, which means we have more likelihood of reaching ovulation. In studies where they only modified diet and not exercise, they had less changes, positive changes in cycles. In studies where they did both aerobic exercise and made dietary changes, they had the most improvements in regulating cycles and achieving ovulation. So lifestyle can make a huge difference. And if you're not seeing results, it's really worth reaching out to someone who has an eye for PCOS, who has experience in treating PCOS, who's willing to listen to you and take a really thorough assessment to understand what's going on in your life and what you've tried so far so that they can give you a customized approach. One additionally frustrating piece, again, I mentioned at the beginning of this podcast that research with PCOS is rather limited. I've actually only found 4 good quality studies that examine the impact of exercise alone on ovulation or pregnancy outcomes on the PCOS population. So like that's frustrating, but overall exercise has benefits. So find movement that you enjoy, find an accountability bunny. Find an accountability buddy or bunny, whatever works for you, so that you can start enjoying the benefits of exercise. One of the questions that came through on Instagram was, is there a cure for PCOS? And I mentioned this earlier just in passing that because there is genetic involvement, there is not a cure for PCOS. However, we can see fast improvements in how regular someone's cycle is, in their metabolic markers, in their overall feeling of well being and vitality with lifestyle and supplemental changes. So I have absolutely have the personal experience of, like, at this point, having regular cycles, having biomarkers that don't indicate that there's any hormonal imbalance. And yet, for myself, I'm really mindful of my environment. I'm mindful of how I eat, of trying to stay active the best I can. And currently, I don't think anyone would be able to diagnose me with PCOS. However, I think if I went off the rails, if I was getting 6 hours of sleep a night, if I was eating fast food every day, if I wasn't taking walks every day, all of those symptoms would very likely come back. The not getting periods, the cystic acne, the anxiety, the sugar cravings, that was part of my personal experience. And I've had many patients over the years who, after we have used our customized protocols, no longer meet the criteria for diagnosis. And we're still going to continue treating them as if they have PCOS because that is, part of their genetics. The last question that I want to address with PCOS was, for someone who feels like they've been doing everything right, they've tried all the things, is birth control really bad? And obviously, for most of my population of patients who is working on getting pregnant, we're not on birth control. But for some of the clients I work with who aren't trying to conceive, they just want to be healthier. They want to be as healthy as they can. They want to be able to ovulate because we know that's a marker of vitality and health. And there's so many benefits of that hormonal picture of ovulation. If we really have tried everything and someone is still not ovulating, or the symptoms of having cystic acne, having hair loss, having weight gain is really impacting their quality of life, I am not anti-medication. I don't love slapping band-aids on something without understanding the root causes. So it's always going to be my MO to understand what this person needs. But for some people, birth control is a very real, very helpful option that can dramatically improve their quality of life. And who am I to judge whether that's good or bad? Every medication has potential risks. There are potential risks with birth control of osteoporosis long-term, of breast cancer long-term. But on the flip side, it's potentially protective for people with PCOS to prevent endometrial cancer. So we really have to look at all risks and benefits of a medication and decide for the individual without, these biases. And I see all of these medications so demonized on social media. And I just think that when we have that black or white thinking, it's not helpful for any patients. It's not helpful for our own learning as providers either. So I don't think that birth control is inherently bad. I think we have to look at the whole picture and the whole person and decide what's going to be best for you. And I mean, the same is true for medications like spironolactone. The same is true for medications like Mounjaro and Wegovy and Ozempic. It's a really hot topic right now, and I'm probably going to get a lot of flack from people who are just 100% anti-pharmaceutical. But I think we need to use the best of both worlds. We need to use the best of what's available to us. And sometimes that's going to be medication. Okay. I want to end this just on a really positive note of, the patients that I've worked with over the last 11 years of being in medical practice, and then, years before that being in medical school. These have been some of the most amazing, dedicated people that I have ever met. And I want better for them. I want better for all of you out there who've been diagnosed with PCOS. I want better for the 25-year-old version of myself who was really struggling to get answers. And I hope that this episode is a stepping stone to getting you better care and better outcomes. And just by being here, listening, absorbing this information, I hope that you're already getting ideas for how you can influence this picture for yourself, improve the chances of conceiving. And if you have questions, I am here. Don't hesitate to reach out to me. I love connecting with our listeners and learning more about you and where you're feeling stuck, what you've tried before. I'm here for you. So shoot me a DM on Instagram. Let me know what you learned from this episode. And if you enjoyed this, if you got something from it, please, please, please take a moment to leave a 5-star review on Apple or Amazon. Let us know what you learned here and what you'd love to learn more about. Thank you all for listening. Happy PCOS Awareness Month. I hope that we can make a change in how this is approached, and I'm wishing you all the best on this journey.